Hello, everybody. Good morning in Latin America. Good afternoon in Europe. And so everybody, welcome. We are having our clinical case series for June. And it is my pleasure to present you Dr. Wilmer Madrid. He's a pediatric pulmonologist in Honduras. And he, with Dr. Daphne Antunez and Nicole Marie, are going to present a case of histoplasmosis. They are presenting from the National University of Honduras. So, Dr. Wilmer, thank you very much for participating. And I give you the word.
Good morning to everyone, and good afternoon in some countries over there. We're going to present today a clinical case, and thank you for the ATS for giving us a chance to show you this clinical case. We are going to expose you a case about histoplasmosis and a immunocompetent patient that unfortunately it was a difficult case to treat, and it was also have a disseminated histoplasmosis that end in the death of this patient. But we will show you some studies how do we do the treatment of this patient. So I will leave you with Dr. Daphne Antunez, that she will show you the case, and then Dr. Nicole Aguilar will give you the review of this case.
Good morning, everyone. So we're going to be presenting, first of all, the case of this patient, as Dr. Madrid already said, and also just making as an introduction that histoplasma has been observed in many diverse areas worldwide. But in the Western Hemisphere, histoplasma is most commonly distributed in the central and middle eastern of the United States and Central America, where it thrives in soils and high nitrogen content. And histoplasmosis is an endemic fungal infection caused by a dimorphic fungus. So also to remember, it's important that the majority of the acknowledgement of the pediatric histoplasmosis cases is derived from case series and case reports, and its management based on data and experience in adult patients. So this is why we like to present this case report, that it's one of the rare cases that has been reported and documented in a pediatric patient. ¿Cómo la vamos a ir para prestar? Pero creo que no salga. No, porque estoy... Pero está en la pantalla, estamos nosotros. Creo que...
Sí. No,
pero sí, pero salimos nosotros.
Vale.
So, can you confirm if you see the presentation?
Yes.
Yes, we can see it.
So this is a patient of 11 years old from Copan, Honduras, with a history of living with human immunodeficiency virus as a vertical transmission in treatment abandonment. He was admitted on December 14th, 2023, to the emergency room from the Mario Catarino Rivas Hospital. That is one of the most biggest hospitals in the north zone of our country. Which were the symptoms of these patients? They were fever, hyperexia, asthenia for 3 weeks of evolution with productive cough for 10 days and associated pleuritic pain. So when the patient came to the next chest X-ray was performed, showing multiple nodular opacities distributed diffusely and uniformly in both lungs, with a slight predominance, as you can see, in the lower lobes. At the physical examination, the patient with a cachectic appearance, pale with multiple neck, axillary, and groin lymphadenopathies, which were less than 2 centimeters in size, hepatosplenomegaly was found on the abdomen examination. And also with the laboratory studies, so he's, So the viral load was 290 copies with only 27 CD4 cells. Virological failure was diagnosed at the beginning, staging in C3 clinical category of the HIV infection. The initial complete blood count, what showed it was bicytopenia. So myeloproliferative process was ruled out. How did we do this? We made a bone marrow aspirate and myeloculture and hemoculture, they were negatives. Suspicion of miliary tuberculosis was investigated also, but it resulted all negative. A bronchoalveolar lavage and bronchoscopy, they were planned to be done to this patient, but they were not performed due to the patient's bad general state. So cryptococci and histoplasma tested negative also in cerebrospinal fluid. The initial pulmonary CT scan that was performed to this patient, it was the one that confirmed the macronodal lesions, as you can see in the image right here, with a tendency to confluence and also showed a cavern-like lesion. It was also made a biopsy of the cervical adenopathies that they revealed the presence of microorganisms in histiocytes that are related to a histoplasma type fungal infection. So it was made a staining in Grocott and periodic acid sheath of the tissue. And what did it report? It reported numerous intral and extracellular cysts morphologically related to histoplasmosis. And in this case, in this tissue biopsy, the antigen and also was positive to histoplasmosis, and it was also positive in the serum sample that was taken. So with these results at this point, antifungal treatment with liposomal amphotericin B and itraconazole were begun in the patient after chronic pulmonary finding. They were started in addition to an antifungal and antituberculosis prophylactic therapy. After 3 weeks of this treatment, the patient still persisted febrile. It evolved towards deterioration with exacerbation of the pleural pain and respiratory failure. So because it was also of this evolution of the patient, an X-ray and another CT scan were made showing more pulmonary involvement, as you can see as the difference of the previously one showed, and with multiple bronchial alveolar calcifications with persistence of the cavitary lesions described as histoplasma. So in this evolution of the patient, unfortunately, he died after 64 days of his hospitalization. So it also, we have to be noted that what we previously mentioned, that the antigen was positive for histoplasmosis in serum, and the patient was treated as if we were treating pneumocystis jirovecii due to the lack of the patient's improvement. We have here, so the videos to show you of the CT scan that were made of this patient. Pero podemos ampliarlo, pero no. Why? In these CT scans, so what did we see, or the radiologist analyzed of the CT scans, he said that there were multiple adenopathies in the jugular and supraclavicular chain, uncountable solid nodules in both lungs, and lung cavern-like thick walls in the superior right lobe. La paramos. Okay, now we're gonna make a review of histoplasmosis, and I'm leaving you with Dr. Nicole.
Well, hello everyone. My name is Nicole Aguilar. I'm gonna continue. I'm gonna make practically a clinical revision of what my other doctor mentioned. So I'm gonna, well, as an introduction, we can see that we have endemic mycosis. This may be it's dysmorphic. It can grow as mold in the environment. It is also an airborne disease that it can assume a different structure when causing infection in the host, and it occupies very different niches in the environment. We can also see that it is more common to see them in the immunodeficient patients. Well, histoplasma is distributed throughout the world, including Africa, Southeast Asia, and Australia. The highest concentration of cases remains the Midwestern United States in states such as Ohio and Central America. So the usual course of this illness is that it is, as I mentioned, acquired by inhalation of airborne conidia. So this is an airborne disease from the environment. The symptomatic disease occurs in a very small proportion of persons infected with histoplasma. Like I mentioned, it is more predominant in immunodeficient patients. It is an ambient exposure that is not associated with outbreaks, and it accounts for most cases of infection with both fungi, can be histoplasma or toxoplasma. It is likely to be the result of infection by very small numbers of conidia, and the incidence of symptomatic infection is higher, and pulmonary infection can be more severe. In the usual course of the sickness, the small number of patients who become ill from histoplasma, these symptoms can develop 2 to 3 weeks later from the moment it is acquired. The initial syndrome is not easily distinguishable from the community. It shows as any pneumonia. It can be clinically not distinguishable from any other pneumonia. So the chest radiographs often show lobar airspace disease, pneumonic effusions, and mediastinal lymphopathy. Saw on the CT scan that my partner showed. So systemic symptoms can be profound fatigue, diffuse arthralgias, myalgias, erythema nodosum, and acute generalized exanthema. The initial infection resolves in almost all persons when specific T-cell mediated immunity activates macrophages to inhibit or kill the fungus. So the histoplasma infection does not guarantee the lifelong immunity. Reinfection can occur with extensive exposure to the illness, and the fungi can remain dormant for years after resolution of the initial infection. The pulmonary nodules after histoplasma infection, we can see that these are the most radiological sign of histoplasma. They're frequently seen, they're usually small, numerous, and calcified as we observed them in the CT scan of the patient that we had presented. It is an uncommon complication, and we can also see broncholithiasis and, mediastinal complications. Several mediastinal complications of histoplasmosis can develop during or after the primary infection. We can have mediastinal lymphadenitis, mediastinal granuloma, and mediastinal fibrosis. The disseminated infection, we can also have disseminated infection in immunocompetent hosts. This event is silent and self-limited as it is with tuberculosis, and multiple tiny splenic calcifications can be noted on the radiographic studies, and that might be the only residual evidence that that patient had the infection once in their lifetime. Disseminated histoplasmosis, it occurs mostly in the adult patients. There are no racial differences. Skin and skeletal lesions are infrequent findings. We can also have fevers, night sweats, weight loss, and fatigue, such as a tuberculosis infection. Symptoms and signs of adrenal insufficiency and painful non-healing oral ulcers. Pancytopenia is also common, and we can have elevated liver enzyme levels. So we can have the disseminated infection in the oral cavity, the primary infection of histoplasma that can be the lung disease, liver, spleen. We can also have affectation of the adrenal glands and the bone marrow. Then to end the conversation, we're going to have the diagnostic methods that, well, The culture and the histopathological assessment remain the definitive means of diagnosing histoplasmosis. So we can observe the histoplasma, the cells may have the halo, and the nuclei of the histocytes can be seen in the culture. How are we gonna make the culture? It is for histoplasmosis, it can grow as a white to tan mold at room temperature on sabouraud agar, and it may take up to 6 weeks for growth. Tuberculate conidia are distinctive but are not proof of histoplasma. We can also have the histopathological assessment that can also be a confirmatory diagnosis. The distinctive features that histoplasmosis has is that we're going to have oval yeasts with single budding found inside phagocytic cells, but also in extracellular spaces. And we can also have antigen assays that can be several commercial enzyme immunoanalytic tests are available. They have a 95% sensitivity in persons with HIV infection and disseminated histoplasmosis with lower sensitivity in those with pulmonary affectations. Not useful for local disease with low organism burden. We can also have antibody assays. They have poor sensitivity in immunocompromised persons who do not have a robust antibody response to infection. They're more sensitive than complement fixation and immunodiffusion tests, but false positive results can occur. And we can also have the complement fixation test that they can show both the mycelial phase and the gist phase, which are more sensitive than the mycelial phase, but depends on reagents used in specific labs. And then the management, well, if we have mild symptoms, then we can choose to have no antifungal treatment, or we can use itraconazole 2 milligrams twice a day for 6 to 12 weeks. And it is a self-limited infection. If symptoms persist for more than 4 weeks, the treatment can be beneficial in the initial pulmonary infection. If we have moderate to severe symptoms or clinically significant coexisting cardiopulmonary disorders, we can also use itraconazole 200 milligrams twice a day. Or we can also use liposomal amphotericin B, 3 milligrams per kilogram day. And then we can continue the treatment with itraconazole for 3 to 12 months. This treatment can be used when we have severe pneumonia and that can require a hospitalization and ventilatory support, just like our patient did. And then we can manage asymptomatic residual nodules. They don't require antifungal treatment, but it is important to rule out cancer in these patients. If we have fever, malaise, cough, or dyspnea, we can also treat them with itraconazole 200 milligrams twice a day for 6 to 12 weeks. If we have pulmonary complications, just as a cavity, we don't use treatment in these cases, and they're not common. We don't have complications that have been seen. Cavitary infection with fever, fatigue, sputum production, hemoptysis, and dyspnea. We can also use itraconazole 200 milligrams twice a day for 1 to 2 years, or posaconazole 300 milligrams per day for 1 to 2 years. This usually occurs in persons that have advanced pulmonary obstructive disease and progressive course if not treated. If we have a ruptured cavity or a pneumothorax, we don't have complications that are encountered. We can also have mediastinal lymphadenopathies. They don't need treatment, or we can use itraconazole to 5 to 10 milligrams per kilogram day in 2 doses for 6 to 12 months. This is seen mostly in pediatrics, in children. We can also use glucocorticoids to treat this affection, sometimes given for several weeks to decrease inflammation. We can have mediastinal granuloma that don't require treatment, or we can use itraconazole 200 milligrams twice a day for 6 to 12 months. It is not clear whether antifungal agents are useful, but often tried, and it can need surgery to relieve compression of the mediastinal structures. Then, lastly, mediastinal fibrosis, it doesn't need antifungal treatment, and the intravascular stenting is helpful to decrease vascular compromise. And well, if we have a disseminated infection, we have to use itraconazole 200 milligrams twice a day for 6 to 12 months if we have mild systemic symptoms. If we have moderate to several systemic symptoms and multi-system environment, as I said, we can use amphotericin B, 3 milligrams per kilogram day, until we have a clinical improvement in the patient. And then when we have the improvement, we can start itraconazole 200 milligrams twice a day for 1 year. And if itraconazole has unacceptable side effects, we can use posaconazole 300 milligrams per day for 1 year for step-down therapy. If we have a meningitis patient, we can also use liposomal amphotericin B, 5 milligrams per kilogram day for 6 weeks, then itraconazole 200 milligrams twice a day, or we can also use voriconazole 200 to 400 milligrams twice a day for 1 year. The duration for this treatment in patients with meningitis is not known. Many patients treated for longer than 1 year, some for life. And I'm going to speak also of the preventive vaccines that we have. There are recent advances in nucleic acid vaccination for severe acute respiratory syndrome. This platform might also be adapted for coccidial vaccine in the future. It might also be successful for preventing histoplasmosis. And that's it.
Okay, thank you. So this was our case for this progressive histoplasmosis in this immunocompromised patient. But unfortunately, he died like 2 months that he was here in the in the hospital, and we treated right by for histoplasmosis. We treated by tuberculosis, but it was a progressive, and it ended with failure in multiple organs. So do you have any questions?
Thank you very much, Dr. Wilmer. And well, we are very happy that you participate in this clinical case, and we know that probably it is great to hear your fellows over there showing us what you are doing. I don't know if somebody, I can see there are some other persons from Latin America here. I don't know if somebody has or have dealt with this kind of complications and diseases in other places. How often do you see it? I can see that there are some friends from Argentina, from Mexico, from Dominican Republic. Do you want to share with us your experience? You can open your microphone if you want. Okay.
No, I think that is a very, like, we have histoplasmosis here in Honduras, in Central America, but it's very rare to see the progressive one. Yeah, we have made some diagnosis and treated, but this patient, because of the HIV state, it was impossible to heal.
Yes, and it was interesting to hear, well, this manuscript that you showed was in immunocompetent patient, right?
Yeah, yes, he was a immunocompromised because he has a C3 HIV stage, and so he left parent very far away from the city, so he doesn't he didn't take his pill for the HIV.
Yes, thank you. Well, we have Dr. Verónica Guerre from Argentina, and she says that they don't have any experience with this kind of histoplasmosis, and well, they are in a huge hospital over there, so thank you for the comment. The same Dr. Floricel Almonte in the Dominican Republic is the same thing, no history or experience, but we have Joseph Markova.
I will put you the tomography.
Yeah. Sorry. Oh, I think we lost Wilmer. Well, Dr. Joseph Macovas is writing that he has an experience with one patient with HIV who has been on suppressive therapy for coming to 3 years. Dr. Joseph, where are you from, or in which country? If you can open your microphone, we are very happy. Oh, thank you, Dr. Joseph.
Okay. I'm currently in the US. I am internal medicine resident. So this patient is my she's one of my primary care team patients. She has had a very complicated course, actually. She was diagnosed incidentally. She had intestinal obstruction and had multiple surgeries. And the biopsy, she was found to have intestinal mass that on biopsy had the granuloma, and that's one of the ways she was diagnosed. And she also had some mucosal lesions, some pulmonary lesions. And I think she was on itraconazole for a while, then to voriconazole, and now has been on posaconazole for a while. We're just monitoring her urine histoplasma antigen levels. They keep fluctuating, and we're managing her in concert with the ID, infectious disease physician. But prior to this, I really had not encountered this, and just the extent of the dissemination, because almost all her in GI, pulmonary, mucosal involvement. She had so many organs involved, but she's clinically stable from a histoplasmosis standpoint. Yeah.
Thank you very much for sharing with us. Okay, so Dr. Wilmer is here, so I don't know if somebody wants to say something else. If not, thank you very much to our friends from Honduras, and remember that we are going to have these cases almost every month. So we are going to share with you the registration. So thank you very much, Samantha, for helping us with this, and Annie, thank you very much. And well, hope to see you soon in our next clinical case.